Good afternoon, everyone, and welcome to today's presentation from the Validation Institute. I'm reporting to you from Portsmouth, New Hampshire, and glad to see lots of attendees from all around the country that have come in to learn about EmpiRX today and the spotlight on EmpiRX. Let me just tell you a little bit, next slide, tell you a little bit about the Validation Institute and what it is we do and why we're doing today's broadcast. The Validation Institute, we're an organization that helps to educate the buyers of healthcare, validate the products and services that they would bring into an organization, and then connect the two. Our mission is, when we look at the tremendous amount of healthcare spend across the country for employers and from organizations for their employees, it represents about $1.7 trillion. And through the techniques and the healthcare point solutions that we're able to introduce them to, they can expect to see savings that can be as much as 30% of their all-in healthcare costs. Next slide, please. So we all know, with the credentials of the folks on the call today, everyone knows that healthcare is a mess. Over $3.5 trillion in U.S. healthcare, skyrocketing, and now with the pandemic, it's all pointing to the straw breaking the camel's back. The way we're going to improve this is through innovation and through organizations like EmpiRX that we're bringing on today. Next slide, please. So we have a three-pronged solution, which is validate, educate, connect. We help validate the organization's marketing claims that are out there in the marketplace, because before that, you don't know fact from fiction, and we have no horse in the race. We have no bias. We are simply comparing the math and the intervention to the marketing performance claim being made. We also educate the buyers of healthcare. So just a little bit of history about the Validation Institute. We came out of Intel and GE, actually. They had a healthcare point solution, just like EmpiRX is here today. They were making a marketing claim. They were making a performance claim so that the employer knew that if they bring this solution in, it could improve quality and lower costs. But their competitors were making performance claims that were mathematically impossible. So they knew there was a problem. They got funding for a third-party entity, and the Institute was born. So this got good traction over the years, but the individual who owns the World Healthcare Congress, Vidar Jorgensen, had started something called the Health Value Awards. And EmpiRX, that we'll be going to today, is a winner of this year's award. And that was all designed to help highlight innovation and high-quality performance vendors to help improve quality of healthcare and lower costs. So it only made sense that as these applicants were coming into the World Healthcare Congress opening for the Health Value Awards, that their performance claims would be validated. And so the two organizations came together and became the Validation Institute. So when I joined, me and my colleagues realized, as we were doing focus groups all around the country, that the purchasing side of healthcare, the employers and the organizations where that $1.7 trillion spend happens, the purchaser side got their education from the exact same establishments that make more money when the rates go up and the services go down. It's just very broken. So much in the spirit of the Validation Institute's roots, we started the Certified Health Value Professional Program for HR professionals and advisors to help educate them on all the areas where they could really move the needle in healthcare spend and improving quality. So we educate the buyers of healthcare, validate the solution that they will bring in, and then we would connect the two. So next slide, please. So, why now? Well, I think everyone knows we're beyond crisis in healthcare. There's studies of the waste and unnecessary procedures that are done, on the ineffectiveness and harmful procedures that are done, on the wasted procedures. And when in comparison with other countries across the globe, we spend 18% of our GDP on healthcare, and we have lackluster healthcare for that. when you compare it against a country like Singapore that spends 5% of their GDP and has the best healthcare in the world. And as Warren Buffett says, this is the tapeworm of American competitiveness. So it's not a matter of if or how we need to do this, it's now. So next slide, please. So we approach this in three ways, as I mentioned. We educate the employer and the organizations that bring healthcare into the organization. We validate the solutions that they're bringing in, and then we match them together. Our education program, I'm proud to say, was accepted by one of the largest professional organizations in the world, the Society for Human Resource Management, SHRM. So HR professionals need to take recertification credits every year, and SHRM recognized the quality of our program, and our courses can count up to a third of the 60 hours of recertification credit. We are also being picked up by business coalitions and groups all around the country because of the effectiveness of our programs. So next slide, please. So now I'm going to introduce today. I'm going to turn the mic over to Karthik from EmpiRX.
Thank you, RD, and thank you to the Validation Institute for the 2020 Health Value Award. And in addition to that, thank you for a little time today to talk about what is different about EmpiRX Health. You heard RD talk about this, but what I especially love about the Validation Institute is this mantra of fact versus fiction. And today's conversation is a little bit about EmpiRX Health and the EmpiRX Health model, and most importantly, what fact looks like in healthcare benefits today. Next slide, please. So before I jump into this slide, right, just want to set the stage a little bit. Very interesting juncture that we're at today, correct? When we look at what's going on from an overall healthcare spend standpoint, the first thing that we see clearly, especially as we go through all things COVID right now, the first thing we see is, while we know hospitals at this point are not going down the path of elective procedures, so one might sit back and say, well, that's great, which means that's going to help, that will help curb healthcare spend in the short term. It's not really the case, because as a result of capacity issues, we're hearing this again and again, right? The entire hospitals are being forced to mobilize themselves as an ER across the board. So you've got an entire facility that is now serving as an ER. And for those of us who've been in the healthcare space for a really long time, we know ER costs are a very significant driver of healthcare spend. So that's the first thing we're seeing. The second thing we're seeing is, I think it was a couple of weeks ago, Modern Healthcare and a couple of other journals published articles about what they perceive as, what they are projecting as some very significant spikes in healthcare premiums. On the heels of that, AHIP, which is an insurance industry trade association, came out with a study where they said they're projecting $556 billion in additional healthcare costs between 2020 and 2021. That's a big number, right? And then the third part to it is, when you look at the mental health tsunami, if you will, that we're in the midst of right now, and that we're going to be a part of for a while, a study came out, I want to say a couple of days ago, maybe a week ago, where it said just in the month of March, we saw anxiety meds spike by about 34%, right? So we know that mental health by itself drives a whole host of physical health conditions, and just the number of additional conditions and morbidities, and as a result, the healthcare costs that will now skyrocket as a result of mental health issues. We can't understate that. So when we look at all of these things in tandem, right, we've always talked about the fact that we have a healthcare cost issue, but we're fast approaching a sustainability crisis. And you heard RD talk about this. I think he referred to it as a tipping point. I'm calling it a sustainability crisis, but we really are at a crossroads. And expecting the same old solutions that have been offered to the market again and again to deliver a completely differentiated set of results, where at that point we're essentially pandering to Einstein's perspective on insanity, right? Trying the same thing over and over again and expecting a different outcome. Right? A couple of years ago, I love this commercial from a couple of years ago. I think it was an online brokerage where you had this dad and his son sitting across the table, and the dad says, son, congratulations, you're working now. Have you thought about investing? And the son says, thank you, and yes, I have. I'm doing some research on the topic. And the dad responds back with, well, I've got a broker I really want to introduce you to. And the son gives him a look and says, well, if your broker doesn't hit your financial goals, will the broker pay back your fees? And the dad is completely dumbfounded. He gives him another look and he says, well, son, that's not how the world works. And the son responds back with, well, it's a new world, Dad. EmpiRX Health is a new world PBM. It is completely different from the way the traditional PBM space operates. And from a financial standpoint, if you peel the onion, if you start thinking about, if you really get to the guts of what is EmpiRX Health from a financial standpoint, there really are two things that play here. One, we put very deep contractual guarantees on the table. These guarantees are savings guarantees. These savings guarantees are both contractual and 100% auditable. You talk about the Validation Institute validating the savings, right? These are 100% auditable savings. And we put these contractual guarantees with what I'd like to call a cover the difference guarantee. If we don't hit those savings guarantees, we cover the difference. We will make the plan sponsor or the plan whole in terms of what we guaranteed versus what we delivered on. That's the first thing. The second thing is very unique because we're a risk-bearing company. It's very unique because what we essentially do from a financial standpoint, we do not make any money until we've hit our savings guarantees. And that is very different. It's a completely performance-oriented model. We have to perform to make money, okay? We're not a startup. We've been around for about 6 years. So when you look at that 99% retention rate out there, that is not just a factor of clients who came to us, and we're one of the fastest growing PBMs in the market as well. So this is not just a factor of clients who joined EmpiRX Health, but this is a factor of clients who joined, and by virtue of a combination of both the financial savings and a service model and service experience that's quite frankly incomparable, they've really stuck it out. So we've got an incredibly high retention rate. On an average, a new client coming into us should expect to see a 15% reduction in their year one PMPMs. And those PMPMs, the reduction, it stays constant. There's a level of sustainability where it doesn't spike back up to inordinately high numbers on the heels of that. Okay? While we really appreciate the fact that the Validation Institute, this is the second year in a row where they've come back and they've given us a resounding thumbs up, we went out a couple of years ago and last year actually, we commissioned a study. We wanted to go out and really have another third party poke holes and pressure test the savings model. And we wanted to pick a brand from a market standpoint that really was a no-nonsense brand. So we went with Milliman, right? I mean, when you think about a company that really signifies actuarial excellence, we went with Milliman from that standpoint to really come in, do a case study on us to really poke holes into the way we saved money and to make sure that we were doing the things we committed to. And Milliman came away so incredibly impressed. They did not only certify the model, they showcased us as a case study on their website. So when you look at the slide, right? I mean, when you look at, I'm not going to go into all of the pieces on the slide because I'm going to cover them elsewhere. But the EmpiRX Health model, again, as I mentioned, from a savings standpoint, is not only deep, but the savings, there's a level of resilience to the savings. So when we talk about a sustainability crisis, this can't be a flash in the pan savings model. It needs to have a level of resilience to it, and that's what the EmpiRX Health savings model brings to the table. Next slide, please. So when you think about EmpiRX Health, right, we hear a lot about value-based healthcare, and we've been hearing a lot about value-based healthcare over the last, I want to say 8 to 9 years now. EmpiRX Health is the only pure value-based PBM in this market. And I'm going to go into these 4 pillars that really start building up, that are the building blocks, if you will, of what is a value-based PBM. But to us, as we think about the voice of the customer, there are 3 things that signify value to us. 1, a significant dent in plan costs. That's the first one. Second, a sustainability level, a level of sustainability as we think about continued reduction in those plan costs. And a third part to it is a white glove service experience that is completely differentiated. And this is differentiated not just in terms of the members, but differentiated in terms of the plan sponsor, the employer, the client in this case, but also benefit advisors who really want to be in a mode as a trusted advisor of the client where there are no surprises. So we look at ourselves and our service experience as something that caters to, quite frankly, we look at this as 4 different constituents. We have a service model that is very deliberate as it pertains to members, clients, benefit advisors, and physicians or the provider in this equation. So when you go to the first pillar on this risk-bearing model, right? I mean, we take risk. We talked about that up front. If we don't hit our guarantees, we cover the difference. We don't make money until we've hit those guarantees, right? So the way I would put this, it's almost akin to an employer who's trying to employ a new, who's interviewing a candidate, right? And they're trying to put an offer together for this candidate, and they're thinking, well, we're going to do the same old stuff, right? We're going to put a base salary on the table, and we're going to put a performance bonus. But what if this candidate, aka EmpiRX in this instance, were to come to the employer and say, I am so confident that I will exceed your expectations that don't give me a base salary, make my base salary performance-based. Give me a base plus bonus only after I deliver and exceed the value that you were looking for from me. That is the EmpiRX Health difference. That is what it means for EmpiRX to be risk-bearing. We take on the complete burden from a performance standpoint, and the clients are technically only paying us after we hit their performance thresholds that we have contractually guaranteed. That's the first component of our value-based model. The second thing from a population health perspective, right? I'm going to talk about population health management, and I'm going to talk about physician engagement together. When you've talked over the years, right? I mean, talking about 20, 25 years, we see health plans, PBMs, talking about condition-based programs, condition-based clinical programs, and we see the same things over and over again. Well, I've got a diabetes program, I've got a CHF program, I've got a COPD program. None of those programs have really done as much as we expected them to in terms of curbing the growth or the trajectory of healthcare costs. So we've taken a completely different approach, and it's worked. This is an approach that's worked in certain pockets of healthcare. It is not the norm, but we've seen this work, especially as it pertains to managed Medicaid and certain other spaces, where we've taken a condition agnostic or a condition neutral approach to our clinical strategy. What we do from a clinical modeling standpoint is we look at a client as a client of one, and every single member in that client's population is assigned a risk score. We use the Johns Hopkins ACG model, which is arguably one of the most sophisticated models in the market for both risk profiling as well as predictive modeling in terms of predicting both clinical morbidities as well as predicting cost. So we use the Johns Hopkins ACG model, and every single member in that specific client's population is given a risk score. And that client's risk profile and the risk score for every one of those members gets updated on a nightly basis as we get additional data on additional claims data, and we process additional claims on a nightly basis, on a daily basis, right? So on a daily basis, we've got a new risk profile for the client, and then we streamline or we target our strategy from an intervention standpoint based on that risk profile of that client. And the interventions are not direct to member, because that would be disruptive to the member. Our model, and I'm going to go into this in a couple of minutes here, our model is completely non-disruptive. Our conversations from a savings standpoint are between the pharmacist at EmpiRX Health and the prescribing physician. And here's the beauty of it, right? If you pull the physician or the provider space, they are tired of having administrative conversations with their plans and their PBMs. They relish the thought process or the opportunity to have a clinical conversation. So we have our pharmacists having a clinical conversation with the physician or the prescribing physician in this case. And essentially it's a clinical consultation where they're trying to work with the physician to figure out if they can switch the medication or the therapy from a higher cost therapy to a lower cost alternative. And they do this higher to lower cost switching in a completely clinical outcomes neutral fashion. So this would be equal or better from a clinical outcome standpoint. So this is a pharmacist talking to a physician, a clinical conversation. So what you have with that is a clinically oriented model driving the appropriate financial outcomes versus a lot of financial gymnastics that you see in the marketplace today. right? It has to be. We are in healthcare. These are not members. These are patients, and we understand that it's clinical first, and we take a clinical first approach to driving the right financial outcomes. And then we envelope this entire thing with what I called out earlier as our white glove service experience. It's a tailored experience. It's tailored on a per client basis. But we are, as a PBM, we were built by someone who started a consulting firm and understood the importance of benefit consultants in this market. And so we're actually we actually put an advisor guarantee on the table outside of the guarantees we have for clients from, whether it's performance, implementation, so on and so forth. We put an advisor guarantee on the table. Every single one of our clients is referenceable. I told you we have a 99% retention rate. Every client is referenceable, and we have a 24/7 model, which essentially means this is not a 24/7 member service model or a customer service model. Our clients and our advisors can reach out to us on a 24/7 basis. And this is important, right? I mean, we've got clients that include correction officers and folks who are by themselves, they are in 24/7 businesses, and it rightfully so, they expect their service partners to be in a 24/7 mode as well. That is the EmpiRX Health service difference. Okay. If we could go to the next slide, please. So this really was the case study. We had a client that came into us 2017. The incumbent PMPM was $90 and change. And at the end of 2018, their number was 7133, a 21% decrease. So the first thing that comes to mind, right? If I'm you, I'm looking at this and saying, wow, that must have been a lot of disruption. But that's exactly the polar opposite of how the EmpiRX Health model works, right? If you're a buyer of pharmacy benefits, or if you're a consultant who's consulting buyers of pharmacy benefits, the thoughts that come to mind are, well, what are these guys doing to really narrow the playing field? Are they really restricting benefits? Are they restricting the formulary? What are they doing from a disruption standpoint to drive that level of savings? So a couple of things that are incredibly important about the EmpiRX Health model. Our preferred formulary option is a wide open formulary. Again, these are patients, they're not members. As soon as a member utilizes that, goes in to fill that first prescription, they cease to be a member, they cease to be just another employee, they're a patient. So our preference is a wide open formulary. 70% of our book sits in a wide open formulary. The only reason we would restrict the formulary is if a client were to come to us very specifically, or a prospect were to come to us and tell us we want a restrictive or an exclusionary formulary. That's the first thing. The second thing, we can be consultative, and we will be consultative, but we will go with whatever the client wants from a plan design standpoint. We've got no plan design puts, takes, here's the criteria, here are the mandated things that you have to do from a plan design standpoint. We have none of that, okay? The plan design, as an employer, the plan design choice is yours. It's what you want to offer your employees, and we are fully supportive of that. You want us to be consultative, we're right there in the trenches with you, okay? That's the second thing. Open formulary, no plan design changes. And then finally, as it pertains to channel, we have no preference. If your members want to go to mail, prefer mail order, go for it. If they prefer retail, go for it. Member convenience from a channel standpoint is extremely important to us. We have a 93% plus adherence rate where members are filling their scripts. And that's a really important factor, right? Because members are filling their scripts at an inordinately high percentage, because when we are out there driving deep cost savings for the client, it translates into significant cost savings at point of sale at the pharmacy, for the member who's at the pharmacy picking up their prescription, okay? So again, open formulary, no plan design restrictions, no channel restrictions. Very important as we think about the financial component of this. We talked about the clinical. This is not a condition-oriented model. What we did with this client was it was not condition-oriented. It was risk-oriented. We've got an 88% engagement rate where when we're reaching out to physicians and we repeatedly reach out, we understand physicians are extremely busy and they will not pick up the phone on the first instance. We repeatedly reach out until we get a hold of the physician. 88% of the times we get a hold of the physician. This is a conversation with the physician, not the physician's office, okay? So 88% of the times we get a hold of the physician. 64% of the times when we have a conversation with a live physician, we are able to consultatively convince them to switch from one therapy to another. And that's where you see some of these numbers. On this specific client, we have close to about 5,400 clinical interventions, 88% engagement from the physician community, about $1.7 million in total clinical savings. Again, I want to reiterate here, right? A clinically oriented approach, a clinical first approach that drives to the right financial outcomes. And then when you look at it from a service standpoint, we've talked about the fact that this is about the member as much as it's about the client, as much as it's about the plan sponsor or the benefit advisor, as much as it's about the provider. Every single one of those constituents in the continuum are extremely important to us. We offer a 24/7 model. Our implementation quality is flawless, and we see that year over year. And what we've put in place is something that we're extremely proud of, and we call it our member care advocacy program. And what we essentially do is, for our most complex cases, we handhold them through their entire pharmacy benefits experience. So from even pre-implementation, prior to going live, and we did this with this client as well, we would handhold those complex cases. We make sure they have what they need. We work on their behalf. They don't have to call into the call center. We reach out to them. We handhold them through their experience with the physician if they need us there, with the dispensing pharmacist, with us as a PBM. We work through all of those moving pieces to make their pharmacy benefit experience as seamless as possible. So the question on the right, I mean, it's kind of tongue-in-cheek, but that really is why EmpiRX. Should your PBM make any money until they deliver on your guaranteed savings? Our belief is no, and that's really why EmpiRX helped. We could go to the next slide, please. So really closing this out, right? We had about 15 minutes, and I really wanted to maximize this in terms of calling out why the EmpiRX Health model has been so extremely successful. I do want to thank the Validation Institute again. This is the second year in a row that we've won an award from them, and we really appreciate the fact that we've won this award for 2 years running now from an extremely credible entity in the market. And for the employers and benefit advisors on this webinar here, if you've got a pharmacy cost problem, talk to us. We know we have an answer. If your pharmacy spend if you've got train wreck pharmacy spend, we know we have an answer. You had heard Artie talk about this up front. You cannot expect the same old tired solutions to produce any level of innovation and any level of difference in terms of bending the pharmacy cost curve. EmpiRX Health has cracked that nut. Come talk to us. Thank you.
Great. Thank you very much. We have a few questions that have come in, and I just want to maybe take a few of those before we get Linda on the phone. And for anyone that's wanting to know more about this particular program that's validated, you can go to the Validation Institute, and you can go to our validation link, and in there you can see validated programs. Just click on that, and you can see it alphabetically and lots of other ways you can sort it. So sorry, I had my webcam there. So we have a question. First question is, does your model work better with certain clients or industries?
Really, it really works across the board, and there isn't one industry versus another where we feel the model's been especially successful. We've got a very significant labor book on one end of the spectrum. We've got some extremely high-end scientific organizations at the other end of the spectrum. We've been extremely successful across the board. Labor has really been amazing for us because it's kept us honest from both a service and a cost standpoint. As I talked about the other end of the spectrum, the scientific organizations have held us accountable from an evidence-based medicine standpoint. So we really have seen very uniform success across the board. And again, if pharmacy spend is a problem, pharmacy spend does not distinguish between one employer versus another. It's either a problem or it's not. And if it's a problem, we have an answer for that.
Great. We'll take one more question, and before we bring Linda on, you talked about no disruptions. How do you drive savings without any member disruption?
The key word you used up front when you kicked this off, Artie, in terms of what we see in this market, right, is just the inordinate amount of waste. And our entire savings model, and quite frankly, is built on, it's a little tongue-in-cheek again, but I would call it waste management. Because what we're essentially seeing by virtue of people getting sicker, utilizers are going up, utilization is going up. The drug pipeline continues to be growing at an incredibly fast pace. And by virtue of all three of these, you've got the trifecta, if you will, that drives, if not appropriately managed, you've got very significant waste that's sitting out there clinically, which is why our entire model is based on engaging the physician in a clinical optimization conversation and a savings conversation versus trying to play games. Again, no formulary changes. We go with an open formulary. We're comfortable with that. We don't expect plan design changes. We're okay with whatever the model is. And we really don't care what channel, mail or retail, the member prefers. We want this to be comfortable for both the plan sponsor as well as the employer and the employee. And we work with physicians to drive the right outcomes.
Great. Lots of questions coming in. We'll get some more of them after, Linda. I mean, just for one common question that I can answer right now is people are asking, will they receive the slides? You will receive after the webinar. You'll receive the recording and the slides. And but with that, I'd like to introduce our Chief Data Scientist, Linda. And can we go to the next slide, please? Great. Linda, are you on?
I am. Can you hear me?
I can hear you just great. You take the stage.
Great. Okay. Well, welcome, everyone. I'm really happy to be here this afternoon. I hope everyone's doing well. So RD and Karthik have mentioned validation in passing, and I can now get into what validation means and what it is about. So when a vendor comes to the Validation Institute with a program to be reviewed, we focus on three things. First is the intervention itself. And has the intervention been shown to have the results promised? So, for example, we might have a diabetes management program, and has a similar program been shown to reduce hospital stays for diabetes? So we do a literature search, look for peer-reviewed literature to establish that the intervention is correlated with the results we're looking at. Now, for some programs that come to us, it's what I would call forehead thumb obvious, that the intervention is results in the outcome. So reference-based pricing would be lower than the typical allowed amounts for services, for example, if that was the program being reviewed. So this is, for most programs, is our first step, except for those super obvious ones where it's negotiating a lower cost. The next thing we look at is the data source and metric. So data sources might be medical claims, it can be surveys, it can be patient assessments, it could be data generated by the participant's interaction itself, so like from wearables, for example. So all different types of data sources can be used. Our focus is going to be on whether the data source is reliable and credible for the measure. In some cases, we might be using a published measure, and so there are standards that have to be met for the data source to be appropriate and to use the published measure as the reference point. So that's our second focal point, is the data source itself. And then the findings. So how is the data used to demonstrate the impact? And what I mean by that is it taking a pre-intervention period and comparing it to a post-intervention period? Is it comparing similar groups of people? Is it comparing its performance to a benchmark? there's all kinds of different ways that data can be used to show impact. And what we're looking for is, how was it done, and is that a reasonable and accurate way to demonstrate the intervention's impact? And then we look at caveats. So what might have altered the results? What are some limitations of the data source or the approach? And we highlight those. And all of these points get summarized into what we call an abstract for each of our validated programs. And if you could go to the next slide, we'll show the abstract. This is a very digest summary of EmpiRX's validation. We do a very short description of the intervention itself. When we need to, we can cite the literature that we've used to establish that link. We describe the metric, which in EmpiRX's case was a 16,000 member group comparing a 9-month period pre-intervention to the same 9-month period post-intervention. And Karthik's slide earlier showed the per member per month cost for the pre and the post period. And then our caveats are this is sort of from the math part of our work. 12-month periods are generally preferred, but the 2 9-month period were the same 9 months of the calendar. So that is stronger than taking, January through August and comparing it to September through June. So our team goes through these steps with each of the applicants. We publish this kind of abstract on the Validation Institute website, and we stand behind it for purchasers who are reviewing these vendors, and they want to know what's validated and what that means, and what we reviewed. We're available to answer all of those kinds of questions. Next slide. Okay, so just briefly here, there's a few different kinds of validations. You can see in that bar across, calculator, savings, outcomes, or metrics. So I'm actually going to start from the right there. A metrics validation is generally for a startup company. They may not have clients running through their program yet, but we have worked with them to create what I call a data plan, so that in 12 months down the road, they will have a credible and valid measure of what their program has done. An outcomes validation means that the vendor has data in their system and they've used a valid and correct measure to show their impact. The difference between outcomes and savings is really that outcomes are non-financial, so that could be improvement in the patient's risk factors. It could be scores on standardized assessments for musculoskeletal function. There's all kinds of different outcomes that are not financial, and that's what that type of validation is about. And then savings is the actual produced dollar savings for the client. And then a calculator is like it sounds, a calculator. But we validate that the assumptions and parameters used in the calculator are based on published literature. So you may have gone online at some point in your life and they said, put in your number of employees and a few more details, and we'll estimate how much money our program could save you. So if you come across one of those calculators and it has a Validation Institute seal, it means that all of the assumptions are based on published literature and or public health data sets, that we have found and applied to the calculation. That's a very kind of whirlwind tour of how our data science team works with vendors and employers on doing the validation review and making the information available and useful to employers. So I will look forward to your question.
Great. Thank you, Linda. So we'll go to the next slide. So you've learned today about validation. You've learned about that the Validation Institute, we're very mission driven. We go out and find innovative and high quality solution providers that are helping lower the cost of healthcare and helping improve the quality of healthcare for employers and organizations like EmpiRX Health does. We identify them, and then we have every year we have the Health Value Awards, as was mentioned, and EmpiRX was a winner this year. There's a prestigious panel of judges from all across America, thought leaders and experts in their field. And this is where the cream of the crop rises and it helps employers to identify high quality organizations. And we will continue to do that. We continue to validate the organizations that are bringing this innovation to the marketplace while educating the employers through our certified health value professional program. And then we connect the buyers of healthcare with the solution providers in healthcare through events like this webinar today, our new Webinar Wednesdays that we're trying to start up, through our online exchange, which you can find on the Validation Institute website, where we have over 1,700 healthcare point solutions now. And if they have a validated program, that they rise to the top and they're clearly identified. And if they've been involved with our awards as a finalist, they also come up to the top and are identified. So check that out. That's absolutely free to the employer and the advisor, everyone that wants to take a look at that. That's becoming increasingly popular as a tool. And then we also hope to see you again very soon in live events where we can face-to-face talk about these great innovations that are happening. We've got a few more questions that have come in, and I'm just going to hit on a few of those. Let's take this next one. You talked about 15% PM reduction year one. What do you see in the following years?
You see, I mean, again, when we think about sustainability and we think about savings resilience, right? We clearly see we see a level of plateauing as it pertains to the savings. So we don't see the savings spike back up and go back to pre the 15% numbers. So the range is always in that 0 to 15. Again, when we look at it on a gross basis, the bulk of our clients actually have flat or negative trend over time with us. So the resilience aspect of the savings is tremendous, even with all of the other factors, as I mentioned, utilization, just drug inflation. There's a variety of different factors that could upset the apple cart, if you will. But what we do clinically prevents that from being upset.
Great. Another question. We're all struggling with poor service from our PBMs. What is different about your service experience? You talked a little bit about this, but what are you doing differently? They want to know.
So, you know, it's a couple of different fronts, right? I mean, when you think about the best service experiences are the ones where they are simple, they're uncomplicated, and you can get to the right place the first time. So when we've thought about the service experiences, right, we understand that we can't have a one-size-fits-all model. So we've done some very deliberate things. One, you know, as we think about first impressions counting, 100% of our contracts are signed prior to go live. And the reason for that is we make the whole contractual experience very streamlined for the consultant who's in the middle of it, as well as the client who's coming on board. Our implementations, I mean, we handhold these implementations to the nth possible degree. As we get into the service experience, you know, what we found over the years, especially in healthcare, is healthcare players have a tendency to think, well, I'm just going to give this client a ton of data and they'll figure it out. So it's almost been, you know, a gigantic puke of data versus saying, I'm going to parse through this and I'm going to give them the information they need to be able to make decisions. So we've got a number of our clients as an example where we will create decks for them to take to their C-suite. So we have HR leaders who will say, well, my CFO wants a 3-pager that really calls out the before and the after and really bottom lines the story for him or her. And we will create something that's very tailored for that audience, right? So it really is about being able to tell the story as much as it's about being able to put a bunch of numbers on a piece of paper. And then we understand this, right? I mean, when we think about HR teams that are really super stretched, the folks that repeatedly walk into their offices it's not the entire employee base. There's about 2 or 3% of that employee base that they have complex cases and they want to be handheld. They want to be taken care of differently. And they're the ones who, quite frankly, should be, because they are the guts of our healthcare system that we need to be embracing more than anything else. So as we've put our member care advocacy programs in place, it really has been about, I call it our virtual hug, but we really are embracing that 2 or 3% of the case complexity. By virtue of doing that, we're taking care of those members. The HR folks are seeing some relief in terms of folks walking in. And as a result, the benefit consulting community isn't hearing as much noise as it pertains to their service vendors. It's a good win-win-win. But with the patient being at the center of it, we really are ensuring we're taking care of them the right way.
Excellent, excellent. This next question actually is for us at the Institute. They asked, what do you do if a company can't be validated? Well, that's a great question. We do get that a lot. We are not a gotcha organization. We are trying to highlight and bring up innovative, high quality solution providers to help improve healthcare. So a lot of times we look at it as it's a marathon, not a sprint. So an organization may come to us and their data may not be in place. They may not have enough data. They may not be bringing it together the right way. And they'll actually work with our team and Linda, and they'll get on that pathway towards validation. Now, there are some things we just can't validate because they just don't add up. And the minute we do, we would not be a valid organization ourselves. So we take that very seriously. But great question. I got another question here. Is your population health management broad for entire population, or do you do something specific for a client?
We look at a client as a client of one. We look at the member as a singular entity within that population as well. So every single member has a risk score that is a combination of clinical and financial risk. And we see this, right? I mean, COVID right now, here's where the risk model importance comes in. When we look at all things COVID right now, irrespective of what the primary diagnosis might be for a person, let's say I was diabetic, right? It's not the overt diagnosis that is creating problems. It's these underlying risk factors that are driving both clinical and financial outcomes for folks who are getting COVID right now. That is just symptomatic of what we see across the healthcare industry at large, irrespective of whether it's entire populations or singular client populations, right? So we create a risk profile for a singular client population on an employee or a patient or a member by member basis. Every single member has a risk score. The entire client has a risk profile, and that risk profile and those individual risk scores get updated on a nightly basis via the Johns Hopkins algorithm. So essentially, the way we think about risk tomorrow for the population might be different from the way we look at risk today for that population.
Great. We just got a question. Could you talk about the technology platform and the use of AI/ML as you build these models and outcomes?
Absolutely. I mean, our models, our entire clinical strategy is very heavily predicated on a level of ML. While, again, when you think about ML from a healthcare standpoint, it hasn't come of age as yet. It's still in its nascency. But what we've done is, as it pertains to the risk modeling, as well as the criteria that goes into the risk modeling, the business rules that drive these risk models and the predictive models that are associated with them, we've built a level of repeatability to those. In addition to that, what we've got, what the data is telling us at this point are, while we haven't really put an ML engine in place yet, and that's one of our goals for this year, what we're able to do with our analytics is essentially uncover questions that we might not even have known to ask upfront as we were building the rules out. So we've really compensated for the absence of an ML engine that we've deliberately plugged in with very advanced analytics But a big part of our goal this year is to really bring in an ML vendor, plug them in squarely into our continuum, and drive essentially the way I would look at it, the next generation of population health analytics from our standpoint.
Great. I got another question. Is there a minimum size employer that you will work with?
We are we have extremely small employers, and we have extremely large employers. We've got employers who are north of who've got more than 40,000 plan sponsors with north of 40,000 members, and then we've got 100, 200 life groups as well. So we do not discriminate on size, and quite frankly, our savings model doesn't discriminate on size either. We're able to make a very deep impact irrespective of client size.
Okay, great. And one more, Kathy was asking, would you consider PGX results if a member had it to ensure a med that works isn't switched to one that doesn't, or switch to the lowest cost alternative that matches the patient's PGX profile?
Come again with that, please?
So I'm going to repeat the question. Would you consider a PGX result if a member had it to ensure that a med that works isn't switched to one that doesn't, or switch to the lowest cost alternative that matches the patient's PGX profile?
Okay, so I'm not completely familiar with the PGX profile, so I will need to
Okay.
to take that one away. What I will say though is this: from our standpoint, at no point, we're a clinical first model. At no point in our conversations with the physician, at no point in our analytics does financial outcomes trump clinical appropriateness. So for us, it's always clinical first, which is why we work through the physician. We understand the physician is the most trusted advisor to a patient, and we understand that we have to convince the physician. And quite frankly, when we look at the fact that we're able to drive a therapeutic switch 64% of the times, we know the 36% in a lot of cases are really physicians saying, well, I've tried that doesn't really work, and I'm going to stick with what I'm trying. Having said that, I will go back and look up what a PGX profile is. If you could give the person in question my email address, I'm very happy to communicate directly with the person.
Absolutely, we'll make that connection. I think we covered a lot of ground today, and I think we got through most of the questions. If there's any others that come in, we will forward them and connect you. As I mentioned, this session has been recorded, and we will send that out to everyone that listened in live. And I appreciate everyone staying to the very end. We have great engagement on this webinar. We also, for those that couldn't attend, they'll be receiving a recording, and it will reside on our website as well. I would encourage you to learn more about validated programs from the Validation Institute by visiting our website at validationinstitute.com. And I'd very much like to thank you, Karthik, today for your time and your sharing of your knowledge, and congratulations on winning the Health Value Award.
Thank you very much. Take care.
Great. Thank you. Bye, everyone.